great. Thank you so much for presenting. We can
Thank
go
you.
ahead and go on to the next presentation.
Hi, everyone. My name is Amy Weinberg. I'm a fourth-year medical student at University of Texas Health Science Center in Houston. And thank you for coming to my case presentation today. We're presenting an acute case of COVID-associated pericarditis and kind of how the management with that patient went. So just to start off, our patient was a 53-year-old woman with a past medical history of hypertension, HFpEF, COPD, not requiring any oxygen at home, CKD, as well as a prior CVA, just with some sensory deficits. And she was on the inpatient setting, receiving antibiotic treatment for sepsis related to a UTI when she developed cough and fever. And at that time, she was found to be COVID positive. About 7 days later, she developed fever again, and then worsening of her cough, as well as some wheezing. And so this is kind of where my team jumped in. I was on the cardiology consult team at this time. But yeah, so the symptoms the patient was reporting were the wheezing, coughing, difficulty breathing, and then fever and trills and night sweats as well. But she didn't have any real like chest pain. She didn't have any changes of her symptoms with different postures, and she didn't feel any palpitation. So objectively at this time, her vitals, she had a fever of 102.7. She was slightly tachycardic with a heart rate of 106. Her pressures were low in the 80s over 60s. Her respiratory rate was 20, and she was statting 93% on room air. At this time, her physical exam, she was awake and alert, but in some respiratory distress with use of accessory muscles to breathe. She did have wheezing on, pulmonary auscultation. And then she did have an irregular heart rate, but she did not have any murmurs or any rubs on cardiac auscultation, and pulsus paradoxus was not noted for this patient. So at this point, with this patient who is COVID positive and having worsening pulmonary symptoms, we're thinking about, does she have pneumonia? Does she have maybe a heart failure exacerbation? Could she be having pulmonary edema, COPD exacerbation? So of course we go ahead and get a chest X-ray at this time, as well as an EKG to address her irregular heart rate. So the chest X-ray is shown in figure 1 on the left here. And the main thing that you see here is just that she has this diffuse cardiomegaly with kind of a classic water bottle appearance of her heart without any real lung consolidation noted for any concerns for like a lobar pneumonia. And then for her EKG, you can see that she is in AFib with RVR, but you can also see that she has some diffuse ST elevations. It's, I think, most clear in lead 2 and lead 1, but also subtle in other leads. So of course, with this diffuse ST elevation, the cardiology consult team was consulted, and we wanted to certainly broaden the differential to look at more cardiac causes. Could this patient have an MI at this time? Does she have some sort of inflammatory cardiac problem like pericarditis or myocarditis with this enlarged heart and this low blood pressure? We're also thinking of an effusion or a tamponade site picture. So we start by getting troponins, of course, and luckily her troponins were negative ×3. And then we also get an echocardiogram that is shown in the middle panel here. So in figure 3A, this is our parasternal long axis view, and you can see that there is some fluid in the pericardial sac around her heart. It measures to be about like 1.2 centimeters, so small but circumferential. And then in figure 3B, it's a little bit difficult to tell. This is our subcostal 4-chamber view, and instead of being nice and plump, our right ventricle is a little bit compressed. And so this is showing that she had some early diastolic right ventricular collapse. Not shown here, this patient also had septal bounce. And then shown in figure 3C, you can see that there is kind of respirophasic changes and the mitral valve inflow on the pulse wave Doppler. So all of these findings definitely alerted us that this patient could be critical. We now know that she has this pericardial effusion, possibly due to pericarditis from COVID, a viral infection. But then we're also thinking about these very pre-tamponade features and concerning for compression of the heart that could lead to cardiogenic shock. So at this point, our team decided to escalate care. We went ahead and transferred her to another hospital where she would be able to get a pericardiocentesis if that were required. And then we also started her on aspirin and colchicine to treat the pericarditis, dexamethasone and remdesivir to treat the COVID, as well as metoprolol tartrate and an amiodarone drip to treat her AFib, and then apixaban for stroke prophylaxis as well. Luckily, this patient did not actually end up needing any surgical intervention. The window for pericardiocentesis was never really sufficient, and her symptoms were mild enough that she didn't warrant the procedure, and she was able to actually respond to the medical management that we initiated. And so on subsequent echoes, we saw that her pericardial fluid decreased, and then the pre-tamponade features disappeared, so they went away. And so kind of the things that stood out to us about this case was it's a very atypical presentation of pericarditis. This patient had no chest pain, and she really had somewhat mild symptoms other than her shortness of breath. And then also, this patient is having pericarditis associated with COVID, which has been documented before, but this isn't necessarily the first thing that we think of with a COVID patient. Kind of looking in the literature a bit, patients who have multiple comorbidities and a COVID infection are more likely to have cardiac sequelae like pericarditis and myocarditis. So it's just something that I guess we need to have in the back of our minds whenever we have a COVID patient who has multiple comorbidities. If they do suddenly worsen clinically, or if their vitals suddenly worsen, that might be a time to be thinking about cardiac problems. Additionally, our patients who have pericarditis or myocarditis associated with their COVID-19 have been shown to have increased all-cause mortality. So this is also just kind of another reminder that if your patient does end up presenting this way and having these problems, it possibly is time to just be on high alert and watch this patient very carefully. But thank you so much for listening to my presentation. I'm happy to take any questions at this time.
I actually have two questions, if that's okay.
Mm-hmm.
The first one is a quick question. Was this patient's EF preserved? I'm assuming so, since you didn't mention any myocarditis.
Yes, it was, I believe, 50 to 55.
Okay. And then my second question was, have you guys seen anything about incidents of recurrent pericarditis in COVID or looked into that at all?
I actually hadn't looked into recurrence specifically of pericarditis. There was literature saying that if a patient has had these problems, they're more likely to get cardiac complications in the future. So I would presume that pericarditis is one of them, but I haven't looked specifically for that piece of information.
Thank you.
Yeah, thank you for your questions.
All righty, do we have any more questions in the audience? All right, well, thank you very much.
Thank you.